My name is Ryan Kowalski. I'm 32 years old, and until 6 months ago, I worked as a surgical technician at Riverside Medical Center in Oregon. I'm writing this because I can't sleep anymore without seeing her eyes. Those wide, terrified eyes staring up at us while we cut into her abdomen. And the worst part? We had no idea she was awake until it was almost over. I need to start by explaining what a surgical tech does, because most people don't really know. We're not nurses and we're not doctors. We're the people who hand instruments to the surgeons, maintain the sterile field, count sponges and needles, and basically make sure the operation runs smoothly from a technical standpoint. It's a good job, decent pay, and I'd been doing it for almost 8 years when this happened. I specialized in general surgery, which means I assisted with everything from appendectomies to gallbladder removals to more complex abdominal procedures. After 8 years, you get comfortable. You've seen hundreds of surgeries. You know the routine. You know what normal looks like. And that's exactly why what happened in OR3 that Tuesday morning in November shook me so badly. Because I knew it wasn't normal. I knew something was wrong, but I didn't know what. And by the time we figured it out, it was too late. The patient's name was Diane Cartwright. She was 54 years old, a middle school teacher from the suburbs. She'd been having severe abdominal pain for weeks, and after multiple tests, they'd found a large mass on her ovary that needed to come out. Possible cancer, but they wouldn't know for sure until they got in there and biopsied it. She was scheduled for an exploratory laparotomy with possible oophorectomy, which is just medical speak for opening up the abdomen to look around and potentially removing an ovary. I met her briefly in the pre-op area that morning. She was nervous, obviously, but she was trying to stay positive. She told me about her 2 daughters, both in college, and how she was looking forward to being recovered in time for Thanksgiving. She had this warm smile and kind eyes. She reminded me of my Aunt Karen, actually. That's a detail that haunts me now, how normal and kind she seemed, how much she trusted us. The surgical team that day was led by Dr. Amanda Voss, a gynecological surgeon with about 15 years of experience. She was good at her job, thorough and precise. The assisting surgeon was Dr. Craig Zimmer, a younger guy, maybe 5 years out of residency. The anesthesiologist was Dr. Harold Brennan, and this is where things get relevant to what happened. Dr. Brennan was in his late 60s, close to retirement. He'd been at Riverside for over 30 years. Everyone knew him, everyone trusted him. But looking back now, I remember noticing he seemed tired that morning, more tired than usual. We wheeled Diane into OR3 at 7:45 a.m. The surgery was scheduled to start at 8 a.m., standard procedure. The anesthesia team, which included Dr. Brennan and a nurse anesthetist named Kevin Wu, got her positioned on the table and started their work. I was setting up my instrument trays, organizing everything we'd need, making sure all the counts were correct. I've watched thousands of patients go under anesthesia. There's a predictable pattern to it. The patient is usually anxious, talking maybe, asking questions. Then they give them the medications through the IV. Within seconds, you see the patient's eyes get heavy. They might slur their words mid-sentence, then they're out, just like that, unconscious. After that, the anesthesiologist places the breathing tube, and the patient is completely unaware of everything happening around them. That's how it's supposed to work. With Diane, everything seemed normal. I watched from across the room as Dr. Brennan administered the induction medications. Diane was talking to Kevin about her daughters. Mid-sentence, her words got slower, her eyelids drooped, and then she was quiet. Eyes closed. Kevin said, "She's out," and Dr. Brennan proceeded with intubation. The breathing tube went in smoothly. The ventilator was connected. Everything looked textbook. Dr. Brennan checked his monitors, the screens that show heart rate, blood pressure, oxygen levels, all the vital signs that tell you how the patient is doing. He nodded to Dr. Voss and said, "We're good to go. Patient stable." Dr. Voss, Dr. Zimmer, and I performed our surgical scrub, got gowned and gloved, and approached the table. The nursing staff had already prepped Diane's abdomen with antiseptic solution, and the surgical drapes were in place, leaving only the area we'd be operating on exposed. Everything was sterile, Everything was ready. Dr. Voss picked up the scalpel at exactly 8:12 a.m. I remember because I documented it on the surgical record. She made the first incision, a vertical cut down the middle of Diane's lower abdomen. Standard midline incision for this type of exploratory surgery. Here's something most people don't know about surgery. Patients' bodies react to incisions even when they're under anesthesia. Heart rate might spike a little, blood pressure might jump, but the anesthesia medications keep them unconscious and pain-free, and the body's reflexive responses are dampened. So when Dr. Voss made that first cut and I saw Diane's heart rate increase on the monitor, I didn't think anything of it. That was normal. What wasn't normal was what I saw about 30 seconds later. I was standing on Dr. Voss's right side, ready to hand her instruments as needed. I had a clear view of Diane's face, or at least the part of it that wasn't covered by the drapes in the breathing tube, and I saw her left eye open, just slightly at first, like she was squinting against bright light. Then it opened wider. I froze. Patients don't open their eyes during surgery. They're unconscious. They're not supposed to be aware of anything. I told myself maybe it was a reflex, some kind of muscle twitch. That can happen sometimes. But then I saw her right eye open too. Both eyes, fully open now, staring straight up at the ceiling. "Dr. Brennan," I said, my voice coming out weird and tight. "The patient's eyes are open." He glanced over from his position at the head of the table. "Probably just a reflex. Check her pupil response if you're concerned." But I couldn't check her pupils. I was sterile, scrubbed in, hands gloved, and ready to assist with surgery. I couldn't break sterility to walk over and look at her eyes. That's not how it works. I looked at Kevin, the nurse anesthetist, hoping he'd check, but he was focused on adjusting one of the IV pumps. Dr. Voss continued operating. She'd gotten through the skin and subcutaneous tissue and was now cutting through the fascial layer, the tough connective tissue that covers the abdominal muscles. I forced myself to focus on my job, on handing her the instruments she needed, on managing the surgical field. But I kept glancing at Diane's face. Her eyes weren't just open. They were moving, tracking, looking around, first at the ceiling, then toward the lights. Then they seemed to shift downward, like she was trying to see what was happening to her body. "Dr. Brennan," I said again, louder this time. "Her eyes are definitely open and moving. This doesn't seem like a reflex." Dr. Brennan actually got up from his stool and came around to look at Diane's face. He lifted one eyelid, which was already open, and shined a penlight at her pupil. The pupil constricted, responding to the light. "Pupils are reactive," he said. "Heart rate and BP are stable. She's fine, just some residual muscle activity." But even as he said it, I saw something in his expression that made me uneasy. A flicker of doubt, maybe, or concern. He went back to his monitors and made some adjustments to the medication drips. Dr. Voss had cut through the fascia now and was separating the abdominal muscles to access the peritoneal cavity. This is the point where the surgery gets more invasive, where you're actually going inside the body. I watched Diane's heart rate on the monitor. It jumped from 72 to 94 in the span of about 10 seconds. "Heart rate increasing," I said. I wasn't trying to be annoying or step outside my role, but something felt wrong. Every instinct I'd developed over 8 years of doing this job was screaming at me that something was wrong. "I see it," Dr. Brennan said, his voice tight. "Giving more fentanyl." Fentanyl is a powerful opioid pain medication. In surgery, it's used to make sure patients don't feel pain even if they're not fully unconscious. But here's the thing I learned later that still makes me sick to think about. Fentanyl doesn't make you unconscious, it just takes away pain. And sometimes, in rare cases, patients can be awake but paralyzed by the muscle relaxants used during surgery. They can't move, can't speak, can't alert anyone that they're conscious. They just have to endure whatever's happening to them. This is called anesthesia awareness, and it's supposed to be incredibly rare. Maybe 1 in every 19,000 surgeries, according to the statistics. But when it happens, it's a nightmare. Patients describe feeling trapped in their own bodies, fully aware of being cut open, able to hear everything, sometimes even able to feel pain if the analgesic medications aren't working properly. And I was watching it happen. I was watching Diane Cartwright experience anesthesia awareness, and none of us fully realized it yet. Dr. Voss had opened the peritoneum now and was examining Diane's abdominal organs, looking for the source of her symptoms. She was talking through what she was seeing, narrating for the surgical record and for Dr. Zimmer's benefit. I can visualize the uterus, appears normal. Bringing the left ovary into view, there's definitely a mass here, approximately 8 centimeters, solid and cystic components. I was trying to focus on what Dr. Voss was saying, trying to do my job, but I couldn't stop looking at Diane's eyes. They were still open, still moving. And now I saw something that made my stomach drop. A tear. A single tear rolling down the side of her face from her left eye. Patients under general anesthesia don't cry. Their tear ducts can produce moisture to keep the eyes from drying out, but they don't produce emotional tears. They don't cry because they're not conscious. They're not experiencing emotions. "She's crying," I said, and this time my voice cracked. "Dr. Brennan, the patient is crying." Dr. Voss stopped what she was doing and looked up at me. "What?" "Look at her face. She has tears. Her eyes are open and she's crying." Everyone in the OR looked toward Diane's face. There was a moment of absolute silence except for the beeping of the monitors and the hiss of the ventilator. Then Dr. Brennan moved quickly, checking her pupils again, checking something on his monitors, increasing medication doses. "I'm deepening the anesthesia," he said. "But her vitals are stable. If she was experiencing awareness, her heart rate would be much higher. Her blood pressure would be elevated." "Her heart rate is 98, I pointed out. "It was 72 when we started. That's a significant increase." "That's still within normal range for a surgical patient," Dr. Brennan countered, but his voice was defensive now. He knew something was wrong. We all knew something was wrong. Dr. Voss made a decision. "We need to finish this surgery as quickly as possible. If there's any chance she's experiencing awareness, we need to minimize her exposure time. Dr. Zimmer, assist me. Ryan, stay focused. Let's move." What happened next was a blur of intense, focused work. Dr. Voss performed the oophorectomy, removing the diseased ovary in record time. Her hands moved with practiced precision, but faster than I'd ever seen her work. Dr. Zimmer assisted perfectly, anticipating what she needed. I handed instruments, cut sutures, retracted tissue, all on autopilot while my brain screamed that we were hurting someone who was awake. And through it all, Diane's eyes stayed open. Sometimes they'd move, tracking the overhead surgical lights. Sometimes they'd seem to stare at nothing. More tears came. Not a constant flow, but every few minutes another tear would slip down her face. Her heart rate fluctuated between 92 and 104. Her blood pressure crept up slowly but steadily. Dr. Brennan had given her every medication he could to deepen her anesthesia without compromising her cardiovascular stability. He'd increased the inhaled anesthetic gas. He'd bolused more fentanyl, more midazolam. He was doing everything by the book, everything right. But it wasn't working. Or at least we couldn't tell if it was working because she couldn't communicate with us. The worst part, the part that still gives me nightmares, was when Dr. Voss started closing. She'd finished removing the ovary, had checked for bleeding, had irrigated the abdominal cavity. Now she needed to close all the layers she'd cut through. First the peritoneum, then the fascia, then the subcutaneous tissue, then the skin. Each layer required sutures. Each suture required passing a needle through tissue. I watched Diane's eyes widen when Dr. Voss began suturing the peritoneum closed. Not a lot, just a slight widening, but it was there. Her heart rate jumped to 108. Another tear appeared. "Dr. Brennan," I said quietly. I didn't know what else to say. I'd already voiced my concerns multiple times. Everyone in the OR knew something wasn't right. But what were we supposed to do? Stop the surgery and leave her abdomen open? That wasn't an option. We had to close. We had to finish. "I know, Ryan," Dr. Brennan said, and for the first time, his voice was shaking. "I know. I'm giving more medication. I'm doing everything I can." The closing took another 25 minutes. 25 minutes of passing needles through tissue while Diane's eyes stared upward. 25 minutes of watching her heart rate stay elevated. 25 minutes of seeing occasional tears. 25 minutes of knowing, deep in my gut, that she was awake and aware, and there was nothing I could do about it. When Dr. Voss placed the final staple in Diane's skin at 9:47 a.m., the total surgery time had been about 95 minutes. Under normal circumstances, that would be considered a good time for this type of operation. But these weren't normal circumstances. "Let's wake her up," Dr. Voss said as soon as we'd finished applying the sterile dressing over the incision. Her voice was tight, controlled, but I could hear the stress underneath. Dr. Brennan turned off the anesthetic gas and began the process of reversing the paralytics, the medications that keep patients' muscles relaxed during surgery. Under normal circumstances, patients wake up gradually. Their breathing becomes stronger as they start taking over from the ventilator. They might move a little, their eyes might flutter. Then they wake up more fully, sometimes confused, sometimes nauseated, but generally okay. Diane woke up screaming. The moment her muscle function returned enough for her to make sound, she screamed, not a confused, disoriented moan, a full-throated, terror-filled scream that rang through the OR and probably through the entire surgical wing. Dr. Brennan quickly gave her sedation medications to calm her down, and the screaming stopped, but the sound of it stayed with me. Her eyes, which had been open throughout the surgery, finally closed as the sedation took effect. We extubated her, removing the breathing tube, and she was transferred to the recovery room still heavily sedated. The OR was completely silent after she left. Nobody spoke. Nobody moved for probably 30 seconds. Then Dr. Voss pulled off her surgical gloves, dropped them in the trash, and said quietly, "We need to talk to the family, and we need to document everything that happened, right now." We gathered in the surgeon's lounge, the four of us who'd been in the room: Dr. Voss, Dr. Zimmer, Dr. Brennan, and me. Also present was the OR nursing supervisor, who'd been called in immediately after Diane left the room. Dr. Brennan looked like he'd aged 10 years in the last 2 hours. His hands were shaking as he pulled up Diane's anesthesia record on the computer. "I don't understand," he said. "I gave her appropriate doses of all medications. Her vitals were relatively stable. There were some elevations, but nothing that clearly indicated awareness. I increased her anesthesia multiple times throughout the case." "Her eyes were open," I said. "She was crying." "Those aren't reflexes. Those are signs of consciousness." "I know that now," Dr. Brennan said, his voice breaking slightly. "But in the moment, with her vitals relatively stable, I thought I was managing it appropriately. Awareness cases are so rare, and they usually present with much more dramatic vital sign changes." Dr. Voss was reviewing the surgical record. "We need to be completely honest with the patient and her family about what might have happened. This could be anesthesia awareness. We won't know for sure until Diane can tell us what she experienced. But based on the signs we observed, we have to prepare for that possibility." The conversation went on for another hour. We documented everything, every medication given, every vital sign change, every observation of Diane's open eyes and tears. The hospital's risk management team was notified. A plan was made to speak with Diane once she was fully awake and with her family. I went home that afternoon feeling hollowed out. I couldn't eat. I couldn't focus on anything. I kept seeing Diane's eyes, open and aware and terrified while we cut into her body. I kept hearing that scream when she finally could make sound. 2 days later, I was called into a meeting with Dr. Voss, the hospital's patient safety officer, and a representative from risk management. They told me that Diane had confirmed our worst fears. She remembered everything. She remembered being in the pre-op area. She remembered feeling sleepy after they gave her medications. She remembered thinking she was falling asleep, but then she remembered being awake. She couldn't move, couldn't speak, couldn't even close her eyes or cry out. But she was conscious. She felt the breathing tube go down her throat, gagging on it but unable to cough. She felt the first incision, a sharp, burning pain across her abdomen. She felt every cut, every pull on her tissues, every suture needle. The pain, she said, was beyond anything she could describe. It was like being tortured while paralyzed. She could hear everything we were saying. She heard me mention that her eyes were open. She heard Dr. Brennan say everything was fine. She heard Dr. Voss say we needed to finish quickly. And she felt every single minute of those 95 minutes. She said she tried to scream, but no sound would come. She tried to move, but her body wouldn't respond. She tried to close her eyes to escape, but even her eyelids wouldn't obey her. All she could do was experience it, trapped in her own body while we operated on her. The only mercy, if you could call it that, was that the medications Dr. Brennan gave did eventually help with the pain, though they never made her unconscious. By the time we were closing, she said the pain had dulled to a severe ache rather than the searing agony of the initial incisions. But she was still aware, still trapped, still experiencing the trauma of it all. I couldn't be in that meeting anymore. I stood up and walked out. I went to the bathroom and vomited. Then I sat on the floor of the bathroom and cried. I know Dr. Brennan did everything he was supposed to do. I know this was a rare complication, a perfect storm of factors that led to awareness despite appropriate anesthetic management. I know that modern anesthesia is incredibly safe and that what happened to Diane was a statistical anomaly. But knowing all of that doesn't help. Because I watched it happen. I saw her eyes. I saw her tears. And I didn't do enough to stop it. The hospital conducted a full investigation. Dr. Brennan was cleared of any wrongdoing. His anesthetic management was found to be appropriate and within standard of care. Diane's case was attributed to what's called anesthetic resistance, where some patients require much higher doses of medication to achieve unconsciousness. It's rare, but documented. There was no way to predict it would happen to her. Diane underwent months of psychological counseling. She developed PTSD from the experience. She had nightmares. She couldn't be in medical settings without having panic attacks. The hospital settled with her financially, though no amount of money could undo what she experienced. I took a leave of absence from work 2 weeks after the surgery. I couldn't go back into an OR. Every time I tried, I'd have panic attacks. I'd see patients being put under anesthesia, and I'd wonder if they were really unconscious or if they were trapped and aware like Diane had been. After 3 months, I resigned. I couldn't do it anymore. I'm working in medical device sales now, a job where I never have to see inside an operating room. The pay is good, the work is fine, but I feel like I abandoned my profession. I feel like I let fear win. But here's the thing, I can't forget what I witnessed. Medical professionals, we talk about first, do no harm. We talk about patient safety and comfort and ethical care. And I watched all of that fail. I watched a patient suffer unimaginable trauma while we were trying to help her. Dr. Brennan retired 6 months after Diane's surgery. He told colleagues it was planned, that he'd always intended to retire at 68, but everyone knew the truth. Diane's case broke something in him. He'd spent 30 years keeping patients safe and unconscious during surgery, and then one day, through no fault of his own, he couldn't live with that. I spoke to Diane once, about 4 months after her surgery. She'd reached out through the hospital, wanting to talk to the surgical team. Most of them declined, unable to face her. But I went. I felt like I owed her that much. We met at a coffee shop. She looked smaller than I remembered, fragile. She told me she didn't blame any of us. She understood it was a rare complication. She understood we did our best. But then she told me about the nightmares, about how she still can't sleep without medication, about how she hears surgical instruments clicking together sometimes when everything is quiet, about how the smell of antiseptic makes her vomit, about how she had to quit her teaching job because being around people became too overwhelming. "I'm not the same person I was before that surgery," she told me. "That person died on that operating table in a way. What came back was someone who knows what it's like to be completely powerless while your body is being hurt. Someone who knows that consciousness doesn't end just because you can't move or speak. Someone who experienced a kind of torture that most people can't even imagine." She paused, looking down at her coffee. "But I also want you to know that I don't hate you or any of the others. I saw you trying to help. I heard you telling them something was wrong. You were the only one who kept saying it, even when they dismissed you. That mattered to me, knowing someone saw me, even if there wasn't anything you could do." I didn't know what to say. I still don't. What do you say to someone who suffered like that while you stood by and watched? I think about Diane every single day. I think about those 95 minutes. I think about how many other patients might experience anesthesia awareness and never report it, or report it but aren't believed. I think about how we trust medical professionals to keep us safe and unconscious during our most vulnerable moments, and how sometimes, despite everyone's best efforts, that trust is violated in the most horrific way possible. This happened 6 months ago, and I'm still processing it, still having my own nightmares, still wondering if I should have done more, said more, pushed harder, still feeling like I failed Diane, even though logically, I know there wasn't anything more I could have done. I'm writing this because I want people to know this can happen. Anesthesia awareness is real. It's rare, but it's real. And if you're ever going into surgery, don't be afraid to talk to your anesthesiologist about it. Ask them about the monitoring techniques they use. Ask them about the protocols in place to prevent awareness. Advocate for yourself. And if you're a medical professional reading this, please listen when your team members raise concerns. I spoke up multiple times during Diane's surgery. I was dismissed multiple times. Maybe it wouldn't have changed anything, but maybe it would have. Maybe if we'd taken the signs more seriously earlier, we could have converted to a different anesthetic technique or taken other measures. I don't work in surgery anymore. I probably never will again. But I'll carry what I witnessed with me forever. Those open eyes, those tears, that scream when she finally could make sound. That's not something you forget. That's not something you get over. Diane is still in therapy. She's working on healing, on processing the trauma, on trying to reclaim some sense of normalcy in her life. But she'll never be the same. None of us will. And somewhere, right now, there's probably another patient experiencing anesthesia awareness. Trapped, paralyzed, aware, in pain, unable to alert anyone to their nightmare. Unable to do anything but endure it and hope it ends soon. That's the thought that keeps me up at night. That's the thought I can't escape. That somewhere this is happening again, and there's nothing I can do to stop it.